to today's webinar hosted by VACCELERATE, which is focusing on health and vaccine safety research using real-world data. As Janine said, please keep your cameras and microphones off during the webinar, and for any questions, please add them in the chat, and there will be some time for a Q&A session after Alejandro's presentation. Before we start, I would like just to share a couple of reflections on the topic that we are addressing today. So real-world data in general refers to information that is collected from various sources in the routine course of patient care. It can be electronic health records, or it can be claims data, or it can derive from patient registries, and more recently, also from wearable devices like our smartwatches, for example. Especially over the last decade, it has become a hot topic, the use of real-world data for research, especially now with the developments around the European health data space. It's gaining increasing attention from different policymakers, from funders, but also from regulatory authorities. The FDA, the EMA are running projects like the Darwin Project, which is focusing on why such data is valuable for research. For example, real-world data can complement results from clinical trials, from traditional clinical trials, for example, improve the inclusivity and generalizability of the results, or help us include people that have different demographic characteristics or varying levels of adherence to treatment of specific drugs. And also it allows us to have longer follow-up periods than the classical shorter-term clinical trials, and include a larger sample size. So we will hear much more on this, on what is happening in the IACS, the Instituto Aragones de Ciencias de la Salud in Zaragoza, Spain, from the speaker of today, Alejandro Santos Mejías, who is working as a bioinformatician and public health data analyst. So Alejandro will explain us what the research in EpiChron, the group that he's working on. And the floor is yours, Alejandro.
Thank you a lot, Maria. You have helped me a lot with the introduction because I will mention probably many of the things that you have already mentioned.
Perfect.
So I have no conflict of interest to disclose right now. And as you tell, right now there is an increasing interest in the European Union to make more available the real-world data that are constantly being generated in the clinical practice. For example, the Darwin initiative that tried to create a unified catalog of these data sources to know in which part of Europe you can access the information that you need for your study in particular. And also not only that, but they wanted to create a common data model to work similarly in every data source, so you can have access, always complying with the data protection law, but allowing at least to have a real data study in the easiest way possible. Not only that, you mentioned the European data space, that the main objective of this initiative is to create the framework, the legal framework. So this reality that is that every day thousands and thousands of millions of clinical data is being generated. This data could be legally useful, and they can be accessible too. For that, there has to be an establishment of common standards and practices. But working with real-world data and in a randomized clinical trial, it's not the same. They have differences. For example, the main one is the scope, the nature of these two approaches. Randomized clinical trials, they try to work with the unknown. We do not yet know how safety can be assessed in this medicinal product, particularly. So they are the gold standard. They work in a very small subset of people with a high homogeneity and in a controlled way. That's totally the opposite of real world data. The data from these studies came from the clinical practice. So you cannot control how this data is generated, or the missingness or the completeness of this useful information. And as you mentioned, it is true that randomized clinical trials, due to the settings, they do not find themselves capable of capturing long-term outcomes, but this can be help and fill with a basic design of real-world data studies. The second main difference is that I want to mention is the study design itself. Cohort in randomized clinical trial, they tend to be small and quite homogeneous. That doesn't happen usually in real world data studies. They tend to be huge. We are talking about millions as basic, and they tend to assess reality itself, and reality is complex with multiple pathologies, with subgroups that cannot be sometimes accessed in randomized clinical trials, like immunocompromised people, pregnancy women. They are hard to work with. So the inclusion criteria and inclusion and exclusion criteria, they tend to be less restrictive in real world data studies than in randomized clinical trials. Also, the last differences that I want to mention is the cost, because real world data tend to cost less to be implemented, and they are easier to implement in a longer term. So with the same quantity of money, just to say that, you can perform a longer studies with this real world data approach. So I just wanted to give you a message that post-authorization safety study, that it's another way of calling real-world data studies, should be seen as complementary to randomized clinical trials, because they work for the same, to understand how the treatment, how this medicinal product, vaccines in our case, is behaving in the complex reality. But working with real-world data can be challenging, above all when we are talking about data quality and data completeness. Most of the variables that we are interested, for example, clinical variables like diagnosis, procedures, use of services, they tend to be trustful and with very low missingness. But this happens because these variables are useful for the clinical practice. They need to be that way. But other variables that are not so useful or are not imposed by law that they have to be recorded, like, for example, sex, age, country of birth, they lack this fidelity, this trustiness. For example, lifestyle variable, what we have seen in my group is that most of the time they are missing, and when they are not missing, they are not up to date. For example, the smoking status, it is only updated when the clinician, the general practitioner, remember that they have to ask sometimes that, are you a smoker? How many cigarettes per day do you smoke? And so on. Or, for example, clinical variables. Some clinical variables, even so they are systematically recorded, they are not accessible yet in some system, in some health system. Like, imagine results, depending on the area, cannot be extracted. And then we have some kind of special cases that some epidemiology groups work with, is environmental variables that they are not missing and they are trustful. The information that they recorded is worth it, but they do not tend to be connected to the health informatics system. So they require a hard work by the research group to connect those variables with the outcomes that you are studying. That's hard work can be done by a research group that has the capability and experience as my own group, the EpiChron research group, that it's centered in the chronic diseases and have access to 1.3 million inhabitants health data from the region of Aragon. You can see the region in the map. And historically, this data can add up to 2 million individuals. Our main goal is a study of multimorbidity, that is the coexistence of 2 or more chronic conditions in the individual. And for that, we have access to several data sources, like primary care, hospital care, emergency visits, pharmacy usage, and some socio-demographic data. So we have a lot of the picture, a lot of the information to assess many of the things that real-world data study require. For that, we have created even our own data cohort that contain almost the full population of Aragon, the 92% of citizens from 2010 to 2020. And with this cohort, we have been investigating multimorbidity. But why multimorbidity? It's because even so there is a low prevalence in our early life, from 0 to 29 years old, it's become the norm, it's become the rule after we pass the 45-year ban. So most likely everyone in the population will be multimorbid, and they are complex, and they are most of the time excluded from randomized clinical trial. And we have seen that in most cases, medicine and treatments, they do not tend to behave the same as an homogeneous and healthy healthy population. For that, we have been interested in polypharmacy patterns, seeing which kind of treatment are associated to which kind of multimorbid patterns. In most of the cases, we have seen that those patterns of multimorbidity are associated to the treatment that are required to treat for the main disease in that pattern. But in many other patterns, we have seen that they are full with symptomatic treatments that are not essential for the treatment of the disease. Also, we are being interested in adherence in treatment adherence, and for that we have stratified with the data that we have the population to see which kind of patients will require more resources in order to be treated successfully. And also we have been participating in different post-authorization safety studies. In this case, I wanted to mention and illustrate the example of cilostazol drug utilization study. It was a study that was centered in cilostazol, a platelet aggregation inhibitor, that was marketed in Europe for intermittent claudication since 2002. In Spain, it was marketed from 2009. And it was associated in the past with spontaneous serious bleeding and cardiovascular effect. So the EMA caught that caught the attention of the EMA, and it implemented some risk minimization measurement to restrict the use of cilostazol in certain patients and reduce the certain characteristic of cilostazol patient. That was performed by changing the summary of product of those characteristics in 2013. And for that, sorry. And for that, the EMA require a drug utilization study before and after the changes. So the objective of this post-authorization safety study was to evaluate the prevalence of new uses of cilostazol before and after the changes, and the frequency of the conditions of this condition targeted by the risk minimization measurement that can be seen in the table in the right. Some of these measurements were just, okay, you have to change your lifestyle, like a smoking cessation, because it's useful for your treatment with cilostazol, and others were more related to the reduction of the use of cilostazol in certain kind of patients. So for that, this study was performed in 5 health databases, 2 of them in 4 different countries. 2 of them were Spanish databases, one the EpiChron group and the other the CDAP, the Catalonian one. And the cohort included 22,519 and 1,821 new users of cilostazol before and after the implementation of this summary product characteristics. So what we have here is that the study will start from the marketed date in each country, that vary from 2002 to 2009 to the 2015, that will be the before period, and in 2004 will be assessed, the after period was assessed. So as you can see, the inclusion criteria are really, I mean, they are not many, there are a few, just to have a prescription of cilostazol during the study period and having at least 6 months of continuous enrollment in the database. There was no exclusion criteria, so most of the cilostazol users were captured during this study. And regarding the result, I just want to mention 2 that are really important and visual. The one was that during the first period, the before period, there was an increased usage of cilostazol until 2012, 2011, depending on the database. And after the changes in this summary of product characteristics, there was a substantial reduction in many of the databases. So the changes were useful and successful in reducing the prevalence of new users. Also, we measure if there were changes, at least a 5% changes in the characteristic that the EMA was interested in. And in many of them, there was a positive change. So they were improved after these changes of summary product. In 2019, the Vaccine Monitoring Collaboration for Europe network was created, and we are part of that. That's why we are now involving in vaccine post-authorization safety studies. This network is a non-profit network specialized in collaborative generation of vaccine real-world evidence, mostly to assess coverage, safety, and effectiveness. It was created during the COVID, so as you can imagine, most of the study has been COVID-19 related, but any kind of vaccine can undergo the scope of this network. There are 27 members across Europe, 15 healthcare data sources covering more or less 150 million citizens. So we have plenty of information to work with. We have successfully participated in 4 public tenders and 4 post-authorization EMA regulatory safety studies on COVID-19 vaccine, but eventually in the future will be a more diverse portfolio. So the way of starting a project in this network is the following. Firstly, a study requester that normally is the EMA propose a research question regarding vaccines. It could be also a pharmaceutical company like Johnson & Johnson, Pfizer, whatsoever. Then the secretariat evaluate this proposal if there is availability of the data and the question is feasible to be answered with the partner that we currently are in the network. If the feasibility assessment is all right, then an open call for the rest of members are established, and everyone that wanted to participate can participate in the study group. Then the study group and the coordination team it's created, and protocol development begin. After the protocol development, most of the time we work in this data workflow. We start with the original data. We have this original data goes through an ETL process that you have to establish and specify which variables of your original data are going to be transformed in which variable of the common data model data. This transformed data undergoes through several level checks to check that, okay, the data that you have transformed follow the structure of the common data model, it is completed, and no missingness in the important variables that you are interested is presented. If everything is all right, these data are considered validated for the common data model that we use, the conception common data model, that is an open source, free, and academic common data model that everyone can implement in the data sources. And after that, we run the analysis scripts we work in a distributed way. So everything is run locally. We do not share any kind of data. That's it, because it's completely or almost impossible due to the data protection laws. And after this script that are tailored to answer the research question of every project, we yield, we retrieve some interim reports, some preliminary results. In many of the projects, this kind of way, or this kind of work way, it's iterative. It's there is not going to be just one interim report. There are going to be multiple, and in this kind of loops, the process will be improved, no matter if it is in the analysis or in the level checks, or maybe the EMA make an amendment and wanted to increase or add another adverse event whatsoever. This process is alive and it's constantly improving during the project. Finally, when we have our final results, a meta-analysis of the different participant results performed, and we retrieve a summary report that is completely open and public. Everyone can check it. So we are part of the post-conditional approval active surveillance study among individuals in the European receiving the Pfizer biotech coronavirus disease 2019 vaccine. In other words, a post-authorization safety study of the Comirnaty vaccine. That's all. The objective of this study was to determine increased risk of some adverse event of special interest. This after the administration of at least one dose of the Comirnaty vaccine. These adverse events of special interest were established in projects before because of the relevancy of lethality or the relevancy of the development of newborns. And most of them are quite burden on health, like myocarditis, pericarditis, Guillain-Barré, or fetal abortion, and so on. Other can be a little bit lighter, like secondary amenorrhea or dysmenorrhea, etc., etc. The second objective was to estimate the incidence rate of adverse event of special interest among some subpopulation. In this case, the pregnancy. In this case, a pregnancy cohort was confirmed. And thirdly, the last aim, the last objective, was to assess utilization patterns along different subcohorts: immunocompromised people, elderly, and subjects with some specific comorbidities. With that in mind, this project is currently running in 8 different data sources from 5 different countries. It's a non-interventional retrospective cohort study, and the study period was from 2021 to almost right now, 2023. We are finishing it yet. In this case, there are more inclusion and exclusion criteria. For instance, we have we have selected only subject that has a minimum of 12 months of active enrollment to ensure that the information is trustful and useful, that there are no history of COVID before the first vaccination, the first date of vaccination, and that those subjects for the subpopulation analysis fulfill the requirement to be considered for those subpopulation analysis. If they are going to be part of the pregnant cohort, they have to be pregnant women. If they are elderly, they have to be of certain age, and so on. The exclusion criteria, the only exclusion criteria that we established was to not having a diagnosis of any kind of any of the adverse event of special interest on the study within 1 year before the vaccination date. So we take out all these kind of subjects that already have these IACS. For that, we are performing a rollout cohort design using a matching process of 1-to-1. In this matching process, what we try is to match any vaccinated subject with any unvaccinated subject that shares similar characteristic by age, by sex, by any kind of other matching characteristics. But some scenarios could happen in the way that, for example, imagine that the first person is the case person and is vaccinated, times 0. There will be a match of this person with another subject that shares similar characteristics, and it is already not unvaccinated. But if during the study period this second person, the control one, is vaccinated, these two couple, this match couple, will be censored, and another matching procedure will be performed to match these two vaccinated people. Another scenario that could happen is that the vaccinated subject get disenrolled of the database because he abandoned the health system. In that case, this matched couple will be totally dismissed and will be not considered for further analysis. And lastly, we will have the last case in which the person that is vaccinated reached the time of analysis, but the control do not reach this analysis because it gets an outcome. So in this case, the match will stop there, but this couple will be used for further analysis later on. Also, as a sensitivity analysis for this project in particular, we have been using a self-controlled risk interval design. What does it mean? Well, for some adverse event that do they have a very well-known risk window and are acute, patients that are vaccinated will be analyzed to see if in those risk windows they have increased risk will have an increased risk that those adverse event happens in comparison with a control period, that it will be a longer time and after this risk event. So I cannot show you yet any kind of result, but if the way of working that is quite easy and straightforward fit it with the way of you working, and you have access to several data sources, you can always join VACCELERATE. So now I'm happy to answer any kind of your questions.
Thank you, Alejandro. And there is one question in the chat. So yeah. Julia is asking, which barriers do you see as most challenging in conducting multinational real-world studies? And she says, I can imagine that national real-world databases differ already widely, especially in a country like Spain, yes, that you are rather regional. I would say you have a more regional approach. Yes. And how can this issue be addressed in such studies? So which barriers and how do you think they can be addressed?
Well, of course, there are many barriers. In fact, in Spain, the way that we work real-world data in Aragon is totally different from, for example, Catalonia or Andalusia. So most of the barrier is the way variable information is recorded. Some data sources use different code systems, so you have to take that into account in order to map those code systems and make an equivalent meaningful reasoning between those. And also the importance that different health systems give to different information. For example, here smoking status, that it's the key element in my head right now. It's recorded in a way that it's not recorded, for example, in Germany. In Germany, they do not tend to ask how many cigarettes per day do you have. They just ask you if you are a smoker or not. So you have to work very closely with the research team in order to assess and evaluate the necessities of your own context for making these equivalencies.
Okay, thanks. And I would have another question, especially for your COVID study, because you mentioned that you started the cohort. It was a prospective cohort, and you started it in 2021, and you are still recruiting, because you mentioned 2023.
Well,
or you are following up.
Yeah. We are following up, really.
Following up,
yeah.
Okay.
We are not. I mean, in real world data, we do not recruit the data. It's already generated, so we just extract it from the electronic health
EHR.
system. Yeah.
Okay. Because you mentioned you have 8 data sources from 5 countries.
Yes, indeed.
Okay, so it's not only within Spain, but the data then it's are you centralizing somewhere or working each one?
No, as I mentioned it, there is no sharing of data because data protection law doesn't allow that in Europe. So we are always working in a federate way. They distribute the analytical script by the Back4EU organization, and you have to run it locally in your data sets. Okay. And the participant of this study in the Pfizer one, we have 3 data sources of Spain, 1 from Norway and several from Italy, and 1 from France, if I don't recall it wrongly.
And did you have to deal with the problem of how can I call it, the temporal considerations of a pandemic? So, for example, the pandemic was evolving, and in different countries, I guess there have been different vaccination strategies, different emerging variants at different points, different vaccines for the general population. How did you deal with such aspects in a pandemic context in your in the frame of VACCELERATE?
Well, that was challenging for sure. In fact, the different data sources started the vaccination in different times. So the date of the start of the study is different from one to another. But in most of the cases, the pandemic was beneficial for this kind of studies, in fact, because the information regarding COVID was highly and well documented and recorded in databases. Right now, it's lower the quality because we have become to a more primary care dependent instead of hospital care. So everything is recorded at a primary care level, at least in Spain. So there is going to be more missingness and less information of high quality.
And is the quality aspect really a problem when running real-world studies to create the real-world evidence, for example, for PASS?
Yeah, it can be a problem because if you cannot identify if the missingness of these variables is due to their nature, for example, if you have a missingness in the date of death, it's because this patient is not dead. That missingness doesn't affect you. But if the missingness of, for example, for instance, the type of vaccines, that's something that has been missed out because the physician, the nurses has not filled out this information to the system. So it's something that we cannot solve and can reduce the way we do association in real world data studies.
And apart from the post-authorization assessment of safety, do you see, or does your group work with any application for building evidence for authorization. You see what I mean? Before asking for the authorization of a drug, to provide complementary evidence coming from...
We haven't yet worked in that scenario, but we are happy to join any kind of project that came of this nature.
And what about synthetic data sets? Because you mentioned a lot the problem of privacy. Do you think that building synthetic data sets based on real-world data can help solve the problem of international collaboration, at least?
It can help solving some issues about all in predictive medicine, that they are constantly using this kind of synthetic data sources. But for assessing the safety, the real safety of medicinal product vaccines, synthetic data cannot be used, because the conclusion that you yield from them cannot, will reflect the reality. You are not sure about that. Probably, but you are not sure.
Yeah, more concrete validation models would most probably be needed for that. Okay, and one last question from me, and then if you have other questions for the participants, please feel free to put them in the chat. You mentioned that in VAC4EU, you are contacted by the EMA or by pharma companies with specific questions. Do you then work closely with them afterwards for defining I don't know, inclusion, exclusion criteria that they want, or the real research question, or are they just coming with a question to you and then you're independently assessing?
It depends on the outcome that they want to measure, but in most of the cases, we work complementarily. We work closely to them. But as a data access provider, as an analyst point, we do not tend to have to deal with this kind of problems. They do it in the secretariat level or in the coordination team level.
And now let's say that the COVID-19 pandemic is slowly fading in terms of importance, at least.
It is, in fact.
For the general public. Is the VAC4EU network focusing on specific other diseases that could be of interest maybe for the people on the call?
We are trying to diverse our market right now. And there are some vaccines regarding, I think, if I don't recall, meningitis and a respiratory disease that I cannot remember. So in those vaccines that are not COVID related, we will be trying to be we will try to monopolize the study of these vaccines. So yeah, we are trying to diversify.
Okay. Okay, are there questions from the other participants? I do not see any other specific question. Then maybe I can ask you a more general one. Do you think that the upcoming European health data space, is Spain ready? From your experience in real world data, is Spain ready for the...
It will be. Right now, it's not ready to support federated, distributed accessing of data from different countries of Europe. And also, there is no structure yet established here, but it will be eventually. For example, for instance, in Aragon, we have a data warehouse that unify all data sources for health. So that's what's going to be the rule in the future, to have this kind of data warehouse that unify all the data sources. But yeah, eventually it will be.
Yeah, because for example, in France that we are based, we have the French health data hub, but in France is not so much, organized by regions. So I guess maybe more easier with the unified healthcare, more
Yes.
unified healthcare system.
In fact, health systems that have a unified one, they tend to have an established structure that make it easier, as you are mentioning. In the case of Spain, we will need that every community, every region have this kind of data warehouse that are unifying and control the quality of the data. And right now we do not have them in all the regions.
Yeah. And another question, I'm not sure, how do you tackle the ethical, legal, and privacy consideration? I mean, do you collect the consent of people when for the EpiChron cohort or for the COVID-19 cohorts that you run? Did you collect consent from the people participating?
We are not obliged to collect the consent because we cannot tackle different specific specific people. So we are, I mean, it's not mandatory when you are working with so many data and the minimization data rules are imposed.
Okay.
But of course, you have to sign a certificate that you are not going to use the data to identify anyone. That's obvious. I mean,
and you're using, I mean, in legal terms, we are using pseudonymized data. You are not using anonymized data.
Yeah, you are not. Of course, you are not using any kind of name. You are always having an ID that it's generated computationally. So you only have data that are the minimal one for your study. For example, instead of date of death, you will have just year of death or whatsoever. They will try to minimize the data that you need in order not to in order to reduce the risk of re-identification of those patients.
Okay. Thanks for the information, Alejandro. It's quite useful, actually. Okay, since I think that there are no more questions, I think that we can close here. So thanks everyone for joining. Thank you very, very much, Alejandro. Thank you, Janina,
Thank you
for the
inviting
opportunity.
me.